Hello, everyone, and welcome to the conference. It will start in just one moment. We'd like to remind participants to keep yourself muted and your video off to help with bandwidth purposes, as we have hundreds of participants from around the world. Questions today will be taken from the chat. If you have a question, please put the word question and then type your question in. If you are in the chat commenting, simply just comment on the words that you are responding to. We will start in just one moment and look forward to another 3 hours of great conversation.
Good morning, good afternoon, good evening, colleagues. Greetings from Pretoria, South Africa. Welcome back to the second day of the 3 days of engagement around the topic of the environmental factors in the COVID-19 pandemic. My name is Joel Ondego Botai, and I'm a chief scientist, and I direct the application research group at the South African Weather Service, which is the official partner of the World Meteorological Organization in South Africa. It's great that there are so many of you who have joined us this morning, and I expect that there will be others joining us later. Yesterday was a very informative day, especially with our two excellent keynote addresses. Dr. Aaron Bernstein, who spoke about a holistic approach to understanding the role of the environment and the ecosystem with this pandemic and others that may occur in the future. His key message is that we cannot consider ourselves as separate from the environment and the way it's managed if we are to avoid such calamities in the future. And actually, if you, I just quote his statement, is that nature is telling us something and we need to listen to it. The second keynote speaker was given by Dr. Rachel, who gave us the insight we need in order to understand how to technically assess the role of environmental drivers in the modulation and potential seasonality of SARS-CoV-2 and COVID-19. In our talk, she has shown us that this is a very complex puzzle, and at this stage, with so many susceptibles, great care will need to be taken to get this done well while accounting for the role of the range of confounding variables. I know that my colleague, Dr. A.J. Smit, will address this today in his keynote. Dr. Rachel spoke about ongoing work in this regard across various locations globally. But I could like to extend an invitation that her work includes the African colleagues, which was notably absent in the work. Yesterday, during the panel discussion, we also heard from Anne Stewart about the connections between climate change impacts and how this has manifested in inequality of impact of COVID and the efforts underway to work hard on the nexus between climate change drivers and the healthy drivers in various programs. Dr. Hirata spoke about some work on COVID-19 in Japan and explained that despite extensive work so far, it has been difficult to extract the information due to the difference in demography and classes of outbreaks there. But he said that there are some signals discernible with appropriate analysis which are underway. It's understood, and we all need to go by the old adage that let us allow data to speak for itself. In Mercedes Pascal's talk, They mention about the emergence of a disease in relation to climate factors and how, as many other examples of infectious diseases, the work mentions that it's likely to be much more important in driving second wave and subsequent reemergencies, as it has in other diseases. She also spoke about what is important in terms of data collection and monitoring efforts. And this is echoed by the the group of Earth observations in their initial statement. And finally, John Palpers spoke about the opportunity we have with such a bewildering array of skills and data sources, from molecular to satellite sources of data. And his message was that we need to integrate these skills and direct them in order to answer the key questions of this symposium for both outdoor and indoor environments. But I'd like to reemphasize a remark from Eileen, Irene herself. She mentioned that we actually need to differentiate the difference between the disease and the virus that causes the disease itself. And in our work, in our own statement, she mentioned of the principle that we need to identify the agent that causes the disease vis-a-vis the disease itself. This is very important as we develop frameworks to understand the characteristics of the disease itself and pandemic generally. All these presentations can be viewed on the AGU Facebook page, and the links can be found in the message on the AGU Connect posted by Dr. Neville Swade. Yesterday's events are recorded on Facebook. I have to say that they have received almost over 3,400 views. So today's program will include a keynote session and another panel of discussion on the potential and limitations of various approaches to integrating environmental and meteorological information to COVID forecasts. And our first breakout session. These sessions will be moderated by my colleagues. So with that, I would like to thank you all, and especially my colleagues on the scientific, the steering committee, and also the AGU, and hope that you will enjoy, extract some learning that you can use, and contribute to the discussions, ask questions in the Zoom chat, ask questions in the Zoom chat, and all the AGU Connect channel. Now I'll pass on to Prof. Chris Gordon, who will moderate the keynote session. Thank you.
Thank you, Joel. I am Chris Gordon, and I am representing the International Science Council Regional Office for Africa on the Scientific Steering Committee of the conference. I'm based at the Institute for Environment and Sanitation Studies at the University of Ghana, and I serve as the CDKN Country Engagement Lead. I also serve on the UN Environment World Adaptation Science Program, the International Standards Organization, and I'm a Earth Commissioner with Future Earth. Today's keynotes will address the problem of applying environmental, meteorological, and climatic information to forecasts and projections of COVID-19. Our first keynote will be delivered by Dr. Madeleine Thomson. Dr. Thomson leads Our Planet, Our Health team at the Wellcome Trust in the UK. She has previously held senior research positions at the International Research Institute for Climate and Society and the Mailman School of Public Health at Columbia University. She has also served as director of the IRI PAHO WHO Coordinating Center on EWS for malaria and other climate-sensitive diseases. After Dr. Thomas's presentation, questions will be moderated by my colleague, Juli Trtanj, the One Health and Integrated Climate and Weather Extremes Research Lead for the United States National Oceanographic and Atmospheric Administration. We encourage participants to type their questions in the Q&A interface in the chat. prefixing questions with the word question, and we will work to get as many of these issues addressed during the conference. Let us hear Dr. Thomson's presentation now. Thank you.
Good morning, good afternoon, good evening, wherever you are. My name is Madeleine Thomson. I work at the UK's Wellcome Trust, a politically and financially independent foundation that exists to improve health for everyone. As one of the world's largest charitable foundations, we are committed to taking on some of the biggest health challenges facing the world today. And I'm delighted to be able to join you at this conference on climate and COVID-19. One of the biggest challenges today, of course, is the COVID-19 pandemic. And Wellcome is currently supporting research and development in COVID treatments. We are also working to make sure that any new vaccines, tests and treatments are mass produced quickly and reach everyone who needs them. While Wellcome may be most known for its work on infectious disease, it has also invested in other areas of research. Since 2015, the Our Planet, Our Health priority area has invested in a community of researchers who are taking on the challenges of food systems, increasing urbanization, and climate change. We aim to stimulate research excellence and develop global collaboration to drive change. One area of increasing interest to the Trust is that of climate change and health. Before coming to the Trust, I was the director of the WHO Collaborating Centre on Malaria Early Warning Systems and other climate-sensitive diseases at the International Research Institute for Climate and Society, based at Columbia University in New York. While there, and I was there for 17 years, my work focused on the development of forecasting systems for various infectious diseases. But I also became interested in how climate and disease interact more broadly, and the relevance of climate information in health decision-making. So today, I want to talk about the impact of climate on COVID-19 and the potential for forecasting systems, which is in line with many of the other presentations and discussions at this conference. I would also like to, however, broaden the discussion to include other intersecting points between COVID-19 and climate, which include the impact of COVID-19 on hydrometeorological disasters and their response, a co-benefit of climate action on the vulnerabilities to COVID-19, and climate and the COVID-19 recovery budgets. So I'd just like to start with a table on climate information opportunities that is drawn from a book I published with Simon Mason, a climate colleague from the IRI. Many of the ideas included in this presentation are elaborated in the book. Climate information at the appropriate scale, temporal and spatial scale can help us to better understand the underlying mechanisms that drive infection and thereby help us identify novel opportunities for intervention. And this was particularly useful in trying to understand the drivers of meningococcal meningitis transmission in the Sahel, work that I was engaged in for quite a number of years. Climate information also can help us look at the spatial risk of and help us identify populations at risk to better target interventions. And this is quite a common practice now we see with many risk maps designed for identifying at-risk populations, incorporating some form of climate information. Climate is also really useful to help us understand seasonal risk and inform the timing of routine interventions. And then, of course, there are the subseasonal and year-to-year changes in risk, which can help identify where epidemic risk is likely to occur and to initiate appropriate prevention and response strategies. Trends in risk are particularly important, of course, with climate change, and this long-term trends in climate may result in shifts in the populations at risk or indeed in the timing of the seasons. Last but not least, I want to point out the use of climate information and the assessment of the impact of interventions. And we found that this has been particularly useful for climate sensitive diseases. And I'll elaborate a little bit on this later on. But for the moment, I think with what we know about COVID-19 or what we don't know about COVID-19 is that any work that we're seeking to do on climate and COVID really must help us understand the mechanisms for disease transmission, give us an idea if there's a spatial component to the risk that we see, and whether or not there's a seasonal pattern to the disease. And it may not just be a seasonal pattern direct from climate, but of course the seasonality of many other aspects of our lives may also be impacting on the seasonality of transmission. It's really, I would say, too early to tell how climate may give us insights into year-to-year transmission or even subseasonal transmission, just because the data, we're only really 6 months into, maybe 8 months now, into this pandemic. We don't have a full year's cycle of data as yet. So one of the things I want to do today is share some of the key learnings from previous research on climate-based early warning systems on malaria and other climate-sensitive diseases. And the first is to understand whether or not a forecasting system is relevant in the situation at hand. And if it is, what other climate information needs are there, and could they also be satisfied? And I say this after quite sort of a long experience in the development of malaria early warning systems. From 1996, when the Global Malaria Action Plan was formed, malaria epidemics were one of the 4 pillars for action. But with the onset of the Millennium Development Goals, epidemics really lost their focus. And for many years, working on early warning systems for malaria, we realized that it was considered to be of marginal interest to the malaria community and also to the malaria funding organizations. It took many years for me to realize that by focusing on early warning systems alone, we missed opportunities for integrating climate information into malaria decision making. Eventually, we understood that climate information was essential to proper reporting to funders on the use of their investments. In short, with a climate-sensitive disease, you need to know if the impact of your intervention is being aided or thwarted by variations in the climate. This paper here describes a simple tool to ensure that climate is taken into account when assessing baseline versus intervention years. In 2014, I participated in a meeting in Tanzania with the Executive Board of Rollback Malaria, national Met agencies, and the National Malaria Control Programs that focused on the role of climate in the delivery of malaria control priorities. What we found was, although the initial motivation for the meeting was around the development of early warning system, the community came together around 3 really important areas of collaboration. And the first, which was the biggest priority, was alignment issues. They needed to remain relevant and to be considered a key component of national development strategies. The malaria control and elimination interventions must be aligned with multi-sectoral policies and processes, reinforced through institutional arrangements. And so what the malaria control community were looking to do there effectively was leverage climate as a cross-cutting opportunity that would position them appropriately within a broader context at the national level. The second thing that concerned them was, of course, reputational risk, and they need to be identified as a trusted national player and funding priority. And of course, malaria programs must maintain and enhance their reputation for effective delivery in the context of climate uncertainty. So if the malaria control programs were not taking climate into account in the assessment of their interventions, they risked undermining their reputation with their major funders, which is the President's Malaria Initiative. And then finally, of course, they were interested in climate information for maximising impact. And this was really thinking about the targeting of interventions in time and space in response to variations in the climate. And then to do this in a way that was cost effective and while improving health outcomes. So of considerable importance when engaging with the health policy community is to be clear about what aspects of the climate are predictable and at what spatial and temporal scale. Common misunderstandings about the quality of data and the skill of forecasts in different regions of the world abound. And this community will be very well aware of the strengths of weather forecasting, particularly in the temperate zones, and the importance of seasonal forecasting, particularly in the tropics. And of course, the importance, but also constraints of climate change scenarios and projections, and how difficult it is to align this information with what is happening at the local level. I say this because it is also critical to understand the spatial and temporal nature of the problems the health community is trying to address. If a forecasting system is to be developed for a single site, or if the same system should be replicated over a large area where much of the input data may be missing. Climate information may also inform longer-term decision-making that incorporates policy cycles, strategic planning, and long-term investments. Getting the space and time horizons for the decision context as well as the climate information is key. Having understood that a forecasting system is needed, then another key step is to understand whether or not a prediction system can be created that has sufficient skill to be useful. This means understanding the sources of uncertainty as set out here. First of all, the problem needs to be really clearly identified. For a climate-sensitive disease such as malaria, we can inform our modelling approach through an understanding of the boundary conditions of the key climate drivers, the uncertainty associated with the initial conditions, such as the amount of infection circulating in the community, as well as the difficulties in parameter setting. Once we have model outputs, we can think that we think are relevant, we need to test them against a known predictant, such as confirmed cases at a health facility over a set period of time. However, it is likely there will be considerable uncertainty as to what constitutes a case and how easy it is to measure one, as we have seen again with COVID-19. Another key learning is always to seek to integrate climate observations and, where possible, climate forecasts into prediction systems. Here, in a recent paper led by my colleague Angel Munoz, which illustrates this principle. It also uses a calibrated multi-model system to integrate both climate and disease models in order to produce an output that tries to capture the breadth of uncertainty of both the climate modelling and disease modelling processes. I'd now like to touch briefly on the challenges of forecasting multiple challenges and the needs to be flexible in our response plans. Cyclones and hurricanes inflict significant damage, and forecasting systems are well developed. When Cyclone Amphan hit India and Bangladesh in April this year, the normal response was to invite citizens to move to safety in cyclone shelters, just the type of environment that would be at risk of COVID-19. Heat waves are increasingly predictable in the extratropics, and this year the Global Heat Health Information rapidly updated advice on heat action plans to accommodate the needs of the COVID-19 response. What we're looking to here is that hazards don't just happen one at a time. They can happen, a number of hazards can happen at the same time, and our response plans need to be flexible to be able to take that into account. I'd like to say a few words now about the intersection of COVID and climate action. We know that COVID is worse in older individuals and those with comorbidities, i.e. hypertension, diabetes, COPD, etc., so-called lifestyle diseases that are commonly associated with air pollution and obesity. During the peak of lockdown, we noticed the rapid improvements in air quality in many cities around the world. It is unlikely that the health benefits of the window of improved air quality will continue, but the experience of breathing cleaner air and the improved visibility, we hope, will help mobilise communities for a greener environment. In the UK, we ran for 2 months straight without using coal in our electricity system. This was the first time this had happened since the Industrial Revolution. What lockdown revealed was the renewables in the UK are now the most cost-effective form of energy, and coal is no longer a primary choice. An important outcome of COVID-19 has been the challenge of public transport, so essential to a carbon future, but now a risk area for COVID-19. The long-term response will likely be a radical reworking of the way we live, including a much greater focus on active mobility, walking and cycling. And this is something that we've seen happening in cities across the world, that local mayors and local communities, governments are increasingly supporting active transport, not only for the health of individuals, the health of the environment as well. I do want to end with a focus on the year ahead. COP26 was planned for Glasgow in November this year. This has now been moved to 2021. This year is a critical year for climate, with many significant global meetings being planned. Much has been upended by the COVID-19 pandemic, including the timing of the economic investments in a green economy. The COVID-19 recovery budgets being discussed and implemented will now carry the action forward to a low carbon future. Action is needed now to ensure that both climate and health goals are integral to those budgets. In 2022, the COP27 process will be based in Africa and focus on adaptation and resilience. What is learned at this meeting needs to be shared broadly to ensure all those who need the knowledge can benefit. Thank you very much for your attention. Stay safe, and I look forward to any questions.
I'm hoping that you can hear me. Okay, my video is now back. Well, thank you very much for that very interesting presentation, which actually brings to focus a lot of the issues regarding risk, the understanding of risk by policymakers vis-a-vis the sort of investments they made. But for me, the very interesting point raised was this issue of risk interlinkages and the fact that we have cascading risk, one risk helping another risk factor, bringing to the fore. So now I would invite Juli to bring up the questions that have been put in the chat, or any other questions which you have that we can direct to the speaker. Thank you.
Yes, absolutely. We have a couple of good questions here. Both of them immediately sort of address the difference between malaria, which is a mosquito-borne disease that has a direct connection, mosquitoes in the environment, versus SARS-CoV-2, which is a little bit different. We don't know about the insect vector there, if there is one. So Madeleine, if you could address how we might apply the lessons from malaria, which has a vector-borne component that is got a clearer connection to climate, and what we might learn from that about SARS-CoV-2. That's one question, and we have another one as well waiting for you.
Oh, well, thank you very much. Yeah, like you say, a great question. And in a way, I don't really want to emphasize the fact that I was talking about malaria. I was talking about malaria because that's where I have a lot of experience. I also did quite a lot of work on meningococcal meningitis, which is another airborne disease. There isn't a vector. And what the point that I was trying to get across is that from a scientific perspective, we can think through various steps in creating models, how we might deliver a forecasting system. But it's also useful to really sort of reverse engineer the question and look at what is needed by policymakers in order to change the way that they would do an activity or make a decision. And that, I think, is really the thing that really struck me was the fact that finding it really difficult to elevate discussions of climate on malaria in the malaria community at a time when there was a lot of resources and a lot of focus on it, when it was focused only on a forecasting system. But once we started bringing into question whether or not they could evaluate their programs effectively, it changed the conversation. In fact, that particular paper was then elevated to the top communication for PMI on how to evaluate malaria control programs, and they had a whole paper on climate in their evaluation thing. And of course, once they're evaluating the role of climate on their outcomes, it's one step away from the development of the forecasting system, because you have to establish what that relationship is. You have to say where it isn't important. You've got your basic impact model, and you're already talking to people who are right in the heart of the financing and decision-making processes. So my intention here is not to focus on a vector-borne disease or a non-vector-borne disease, but really highlight the engagement point with decision-making and really trying to understand what are decision-makers having to do today, or what might they need to do in a year or two once the disease has progressed around the world more, and then start thinking about what tools would be relevant for their needs.
That ties in nicely to some of the conversations we had yesterday about what we can forecast now, given the lack of herd immunity, for short answer. So a couple of other questions here are about again, if it's going to become endemic, what would you suggest that we do in terms of being prepared so that, and I think you kind of just answered that, can we begin to model COVID-19 in the context of anticipating that we're going to need it in the future, even if it's not as relevant now? So a few questions about that, if you could just maybe answer a little bit more on that. And then we'll move to something about the lead times and what we think we can actually reasonably do weather versus climate scales now. So,
yeah. So it was clearly we're in a very new phase. We have an entire planet of non-immune people. Immunity is beginning to creep in, but largely non-immune. And this is the absolute epidemic phase of the disease. My understanding, and honestly there are many better experts on this than me, is that the disease, if we don't get a vaccine, eventually will become endemic. We hope we get a vaccine, and if we have a vaccine, the best thing will be, how do we target that vaccine most effectively? And a question that arises is that, is a vaccine that is not 100% effective still useful? And one of the things we've seen from work on malaria is that if you have a seasonal disease and you have a vaccine that only works over a short period of time, it can still be effective if you time the vaccine right, because effectively you cut the epidemic early on, and you get through the season with a lower number of cases. So in terms of thinking through the types of vaccines that might become available, and I think we could actually just plan a whole set of scenarios. We don't get a vaccine, yeah? We don't have good therapeutics. Or we get a vaccine but no good therapeutics. Or we get good therapeutics but no vaccine. We get a partially effective vaccine, but it only lasts 1 year. So if we sort of started to map out all of the different scenarios, we could say that, yes, trying to understand the seasonality of the disease and understand what the climate components are may help us with a partially effective short-term vaccine, which is quite possible in the scheme of things, that we won't get a fully effective vaccine immediately. So
Great.
I
Thank
think we
you.
need to think through different scenarios.
Yes, I'm afraid we need to move on to the next presentation. There are a lot of questions still unanswered for Dr. Thomson, and including things about Wellcome funding, but we do have to move on to our second keynote presentation, which is from Dr. Smit. Dr. Smit is an associate professor of biodiversity and conservation biology at the University of the Western Cape, South Africa. He has diverse research experience with multiple projects related to problems of drawing meaning from complex data. He also recently authored a review paper on environmental drivers of COVID-19. So could we have Dr. Schmidt's presentation now, please? Thank you.
Right, greeting from South Africa, everyone. I'm presenting here from Cape Town in South Africa. The title of this keynote that I was invited to present is Winter is Coming. It's basically our perspective of the unfolding COVID-19 pandemic across the world from our point of view in the Southern Hemisphere. I am AJ Smit. I'm based at the University of the Western Cape, and I'm presenting on behalf of all of my collaborators, whose names are mentioned there. The intention of our group, SURGE, was to provide some insight or some assistance to the various communities within South Africa responsible for modeling the unfolding of the disease here locally in South Africa. This paper that I'm presenting today is the culmination of some of the work that we have done towards providing the parameters that could feed into the local epidemiology models. And some of this work has also resulted in additional talks that we will see at this conference. Another publication is the one written by my colleagues François Engelbrecht and Bob Scholes, which was submitted last week or 2 weeks ago to Nature Scientific Reports, which is looking at the test for COVID-19 seasonality and the risk for a second wave here in South Africa. And François is also going to present his results of various simulation studies on COVID-19 in South Africa, specifically looking at the possibility of seasonality seen in the disease and in the virus. Another reason why we did this review and why we thought SURGE was necessary is because we thought that at the time when the pandemic was mostly prevalent in the Northern Hemisphere, that many of the studies that were published at the time were very much focused on Northern Hemisphere challenges, and it ignored many of the things that we in the South think are important. So we went about collecting all the publications appearing about COVID-19 and the environmental mediation of the spread of the disease, which proved to be a big problem because most of the publications at the time, starting beginning of March and going up until about the middle of July, when we finalized our review, most of those publications ended up being preprint publications, and they appeared very, very rapidly. Every week, almost every day, there were new publications about the topic. Another challenge was that many of the studies looked at very local scale, in other words, issues particular to a particular city or country, while other studies looked globally. And there were also studies who looked at the disease right at the beginning, right at the onset of the disease at a particular place, and other studies looked at a combination of different countries. So it means that in terms of the development of the disease, it's very much unsynchronized across space and time. And this also creates various challenges when one wants to look at the weight of evidence across all of these various publications. So let's have a look at what we did. So we basically approached our work by looking at all the publications as available at the time. And we informed our work based on the knowledge of biology of the virus and the epidemiology of the disease. So our paper is structured around that model that you can see in the middle there, and we make sure that we focus on the various points in that model where the environmental influences, as you can see there in red, are able to affect the rate parameters of the spread of the disease around the world. And this influenced to a large degree what we permitted into our study as the most suitable studies to be able to come up with a conclusive answer, or at least some sort of suggestion in the direction that the environment might have an influence on the viral and disease dynamics. So our paper outlines why we think the Southern Hemisphere is very different. And then we specifically have a study that look at the various monitoring and modeling efforts that are underway and how people generally go about trying to understand how the disease spreads around the world. And we look particularly at issues of data. We look at the various epidemiological models, such as the SEIR and SIR models. And we also try and provide a basic synthesis about the various different ways in which the environmental drivers are incorporated in the epidemiological models. And we find a lot of support also from other earlier respiratory viruses, viral diseases, that provided a lot of strong support for our thinking that similar mediators will be present for COVID-19. And to that effect, we do a critical assessment of many of the studies that have been published to date. So just to be clear right at the beginning, our approach is not a full PRISMA compliant review. So we do not aim to track, all of the various reasons for why some papers have been excluded and why others have been included. I mean, of course, we do develop a framework under which we review our findings, but because most of our publications were not peer-reviewed, it was very, very difficult to apply a meta-analysis. So we basically avoided that route, which would have been completely impossible. For reasons I'll explain a little bit later on, but we made sure that in 3 of the databases, the more popular databases, Google Scholar, PubMed, and there was also a COVID-19 database maintained by the World Health Organization. We made sure that we applied a consistent search across all of those, and I mentioned there the number of articles that we retrieved from those searches, and our search went up to 8 July 2020. And then we selected only the papers that promised to provide insight into the rates of infection as a function of the environment, and we didn't really look at studies that incorporated only data on mortality rates. So we were not interested in mortality rates at this particular point. So the outcome, our final list comprised 42 peer-reviewed publications and 80 peer-print publications. And those, my colleague Jennifer Fitchett, who is also presenting at this conference, she will provide a synthesis of a bibliometric analysis applying to all of these studies that we extracted. Very, very interesting patterns that come out there in terms of who participated very early on in providing all of this information. Okay, so we did not, also need to stress that we did not, for the preprint papers, we did not fully review these papers. I mean, it's of course for us impossible, considering how many of these preprints there were, to do for each one a full, thorough, comprehensive peer review process. That's really beyond our ability. It's really not possible at all. So we also are very careful to not put too much emphasis on the conclusions based or arrived at by these various preprint papers. So we extracted various necessary bits of information from the papers. This is a page from the supplement that we submitted together with our publication, and we extracted, you can see the titles of the columns, information about the countries in which the studies took place, the time span over which they acted, whether people incorporated some degree of accounting for the lag between the environment and when the response variable was taken. We make a list of all the various independent variables. These would be the things such as the various environmental drivers that we know are also important in some of the other respiratory diseases. And we also take note of the dependent variables used, the various statistical approaches applied, and then we see whether the studies take into account the multitude of possible confounding influences that might be available. And then we also note whether they take account of the non-pharmaceutical interventions. All of this information we extracted from each and every one of those papers, and based on this we could develop our synthesis of the findings. So this is just one of the first findings, sets of findings, and one of the subheadings under that particular chapter, under the critical review section of our review, lists all the various different environmental influences. And these ones are basically mirroring the influences known to also affect the multitude of other respiratory viruses there. And we make comments about whether they use daily data, whether they use averages of a certain period of time preceding the metric, the response metric, all the various different ways in which people have used the data. We take note of that, and later on we comment about that. There are many, many different ways of doing the analysis, and we don't think that each and every one is equally valid, and certainly how one would use the environmental variables, how you would parameterize the statistical models that would search for the influence of the environment on COVID-19 transmission rates, is going to depend very much also on how the data were used in the statistical models. So we comment on that. Then another very important section in our critical review portion of our paper is how the various studies that we reviewed used as a metric of the rate of spread of the disease, which of the various different ways of measuring the rate of the disease people used. So one of we believe the more correct ways to go about solving this problem is to use the basic reproductive number R0, which basically talks about the rate of spread of the disease or the virus from the time when from when the virus is first introduced into a country, omitting of course all of the people that are moving into a country and bringing the virus with them, when the rate of spread starts to happen because of local transmissions, up until the point where the community or the population becomes aware of the fact that there's a disease and the social behavior changes, or up until the point where the non-pharmaceutical interventions become effective. So the R0 is implicit. I mean, those two characteristics are implicit in R0. So that's a very, very important thing, because it really it talks to the local rate of transmission of a virus when all conditions are optimal for its spread. Of course, the various local idiosyncrasies will be encoded within R0, such as the different social behaviors of people from place to place. And we also think that if there is an environmental signal present, it would be present within R0. We argue in our paper that using the effective reproduction number is not important or cannot work very well. It can, I suppose, but it has a very low signal to noise ratio, because RT is something that varies on a day-to-day basis and is very much subject to the way in which people respond to knowledge of the disease present in their community. So people's mobility patterns are going to change, the expectations of governments on their societies are going to change, and so on. So, that just brings an additional level of interference into the analysis, which would obscure the already quite, we believe, small influence that the environmental drivers might have. Another valid way of looking at the rate of spread is to derive some sort of a parametric estimate, again on that early phase of the transmission of the disease, up until the point where people become aware of the disease or when non-pharmaceutical interventions come into play. So that's basically estimating a rate parameter or a doubling time or something like that. And again, it assumes, or I expect that one would assume that, taking into account the time when non-pharmaceutical interventions come into play, become enforced in a particular country. So those rate parameters need to be estimated from that portion of the curve before NPIs are introduced. And then there are some other ways that people go about estimating these things. So they might say that they only look at the rate of spread over the first 28 days, or up until there are 20 or 200 individuals infected in a particular time, and then they fit a linear model there. And it could work, but it doesn't take into account the effect that the rate of transmission is accelerating, and it's not a linear process with time. And some other studies look at the number of ICU beds, but that of course only accounts for the very severe cases, and it neglects all of the others, so it doesn't give us a full understanding of the full extent of the spread of the disease in a particular country. And then some other studies somehow manage to use only the daily new cases or cumulative cases, which we don't think really work very well. But the important considerations here is that one must limit the data entering into our analysis up until the point when the non-pharmaceutical interventions come into play, and one must make sure that we only use the data or the transmissions resulting from local transmissions, rather than and excluding introductions via mobility patterns, connectivity between adjacent cities or countries, and so on. And then we also made a list of all the various different statistical models that people use. There's a whole variety of them, But we argue in our analysis that it's mostly these parametric models, and there's a whole range of different parametric models that one could use. These are generally regression kinds of models that one could parameterize properly to account for the link that the environment might have with the rate of spread. And this is important because this allows one to set very clear and precise hypotheses, which is necessary, and very few of the studies actually provided suitable hypotheses for testing. The rest of the things are either semi-parametric methods or Bayesian methods. But of course, the Bayesian methods will also work, but there were very few studies, if any, that looked at Bayesian methods. The correlations are not necessarily suitable for a variety of reasons that we explain. Simply, one of the biggest reasons here is, of course, is that it doesn't allow one to really account for the various confounding influences that will inevitably be present, and the parametric models will definitely allow one to do this. There are some machine learning approaches, and ecological niche models are not at all appropriate. I was disappointed to see that very few people used the opportunity created by multivariate methods. I believe that there's a huge scope for future development there, and then some of the studies used inversions of the mechanistic epidemiological models, and the paper that Francois Engelbrecht and Bob Scholes will present at this conference is of that class of model. For our analysis, for our paper, we focus mostly on the statistical models that search for a statistical link between environment and disease dynamics. So for the rest of the talk going forward, I'll mostly only look at the studies that have undergone peer review. I will mention one or two of the more promising preprint publications. Our selection criteria include that they use the appropriate environmental data as an influential variable, that they rely on either a parametric estimate or R0 as the dependent variable, and that they do suitably account for the various policy interventions that come into play at some point during the disease transmission in most of the countries so far around the world where the disease has appeared. This is implicit, of course, in R0. And we also require that for a study to yield suitable results, that they would account for the various potential confounding influences, specifically where the studies are comparing different cities or different regions or different countries across the world, because each one of them will have their local idiosyncrasies, which, if you omit them from the analysis, will definitely mask and obscure the much weaker environmental influences that will also be present in the signal. So the idea is then for all of the statistical models to appropriately account for all the sources of additional variation over and above that of the environment, which is the main influence for which we want to find evidence for. One wants to make sure that you omit and discard all of the noise and enhance the signal to noise ratio as far as possible. And the regression type models are appropriate for that kind of approach. So there was one study, only one study, peer-reviewed study, that, according to the various criteria we applied, yielded what we think is a plausible finding, because the statistical and data selection framework, all of those things were appropriate. In this particular study, I'm not going to name names here. You can read the paper. I think the link is provided somewhere in my talk, or you can email me. That particular study looked at 227 Chinese cities, and they looked at the effect of temperature, relative humidity, UV radiation on the response variable R0. And the outcome of this study was that there was no measurable influence of environment on the rate of transmission of the virus across the 227 Chinese countries. Unfortunately, this particular study, even though everything happened within China, it did not account for the differences that might exist, such as population density, mobility patterns, everything else that culturally might be different and socioeconomically might be different between the various different Chinese cities. So without really accounting for those things, it's very, very difficult or very plausible that the omission of those influences will have masked the true climatic signal, if it was present at all, which could have explained the null result that this particular study had. There were a couple of notable it's a mistake here. These are preprint studies, 9 preprint studies that found some level of evidence or no evidence. So UV radiation came out in 2 of the studies as being present globally. So UV radiation maybe has an effect in a global assessment of the rate of transmission of COVID. Another study found that neither temperature nor humidity globally has any effect on the rate of transmission. And 2 other global studies provided evidence that there's an optimum temperature at which the viral transmission is most rapid. And another study provided evidence for an optimal relative humidity in one of the studies. This was also, I think, a global study. And then another couple of studies, 3 studies, one global, one in China and Singapore, and another one in the United States, showed evidence. They didn't show that at what the optimum temperature relative humidity is, but they did show that relative humidity and temperature, lower relative humidity and temperature, enhance the transmission of COVID-19. And this was generally the feeling I think that most people had early on around how the environment modulates the rate of spread. Another study found that mobility is something that really needs to be taken into account, together with some of the other environmental drivers that people are generally studying, and this is something that I can definitely agree with. It has a very strong signal in the studies where mobility was included in the analysis. It had a major influence on the rate of spread of the disease when it studied in combination with temperature and humidity and so on. And some other studies found completely the opposite, that higher temperatures and high amounts of particulate matter in the atmosphere, aerosols and so on, or not aerosols, but pollutants in the atmosphere enhance the transmission of the virus. So this higher temperature is completely the opposite to any of the previous studies. So very little consensus, it seems to me. So based on our expectation that we had from our understanding of how other viruses work, other viral respiratory diseases around the world, we had a very strong expectation that COVID-19 would respond in the same kind of way. And early evidence seemed to show that lower temperatures and lower relative humidities would be conducive to the spread of this disease. But once we started to look at all of these various different studies, the 122 reviewed and peer-reviewed publication, once we subjected those to a deeper analysis, it seems that overall, although there are some studies that show that there is a temperature and humidity effect, that the balance of evidence seemed to suggest that at the moment that it's still very much inconclusive. I definitely would not say that with 100% certainty, or even with 20% certainty, that this is the case. So the COVID epidemic is unprecedented in many ways. Of course, it's a novel disease, so the amount of data that we have available to work with at the moment is sparse, but it's also novel in the sense in how the scientific community has responded. And it's resulted in a flurry of papers. There's so many papers that have become available. Unfortunately, most of them were rushed, and they were of quite poor quality mostly. And the data are also fairly incomplete. Remember, we are right at the beginning of a disease. We have not experienced anywhere in the world a full seasonal cycle, so the effect of seasonality is very much unknown. Temperature-mediated effects, I think, is a greater possibility that we can arrive at some kind of understanding there, because we could make do with smaller studies replicated at many different places around the world, each one with its own unique climate and temperature, humidity, and all of the rest. So that might work in a properly parameterized statistical model of those kinds of effects. But that, of course, depends on whether we understand properly the distinction between R0 and RT, the basic and effective reproductive numbers, or the parametric estimates of the growth constant, which effectively has the same role as R0, because that's where the signal-to-noise ratio is highest. A conclusion that we can also reach here around the assessment of all the studies to date is that many of them, even though they work on local or global scales, there are so many confounding variables that people have omitted that make it very, very difficult to really put a large degree of certainty on the outcomes of the studies. And something that we were particularly concerned about from our point of view here in the global south, in South Africa, and many other developing and poorer regions in the world are in the southern hemisphere, that many people here are already fairly stressed because of comorbidities such as HIV/AIDS and TB. Many people are very poor. The GDP of many of the countries are quite low. So you imagine that people would be quite susceptible to the disease, which at the moment, I don't know yet. So we need to do a full analysis to understand it. There seems to be a relationship between viral transmission and GDP, a country's GDP. But to exclude those effects from the models, statistical models that look for environmental drivers, that hasn't really permeated deeply into any of the statistical analyses that we have seen. They have happened from place to place. There are studies that have looked at GDP. So, but I think there's much room for improvement. And there's the double lag jeopardy, which means that there's a large amount of variation or uncertainty in the our knowledge around how long, what the time is between infection and when symptoms are first showing, because that's going to influence when people are going to go for testing. And then testing, of course, and reporting, there's often up to two weeks lag between the two. So those two things, of course, together make it very difficult to properly parameterize a statistical model. So a lot of new insight need to come from there. There's many deficiencies, even in the United States and in South Africa, all the places around the world, many places around the world, in terms of how testing happens and how quickly reporting of those results become available. So a lot of certainty around, or removing some of the uncertainty around that would create a situation where we can have a better understanding, or the data that enter into these statistical models would be more believable. So I do need to also, near the end, it's my second last slide, also have a basic comment about a perception of the quality of science that we have seen, especially in many of the preprint publications. There's been many of the studies were unfortunately quite poor in execution and in how the necessary levels of details were reported in the publications. None of them, or very few of them, were fully reproducible. You know, I think it's generally understood today that one can report even the precise details around the statistical analysis quite clearly online in all the various different open repositories of information, of digital code. And this is a practice that has really not been noticed in most of the studies. I'd say 90% of the studies, if you read over the methodology sections, they are so poor in quality that it's very difficult to replicate the study. Certainly none of the source code, none of the data are available anywhere for people to have a look at. And this is important. It's really important for an emerging disease such as this, because, you know, decisions are being made that weigh, you know, decisions are being made that place either emphasis on economic well-being or on people's lives, and it's with global consequences, with long-lasting consequences. And we need to be very clear that and certain that the way in which the studies have been undertaken is believable. So I would really hope that in the future people put a lot more emphasis on the quality of writing, on the quality of reporting the exact details that go into an analysis. Often it's just not at all useful. And this is, of course, quite important even for local studies, because I think much of the information that we require about environmental modulation of the disease going forward into the future is going to depend on meta-analysis, where isolated studies, localized studies around the world will be analyzed in a meta-analytical framework. And from that point of view, for studies to be useful for meta-analysis, statistical rigor is quite important, and one needs to pay attention to how the data have been reported. Thank you very much. And I need to acknowledge the GeoHealth for sponsoring the conference, to the AGU for hosting the conference. And I was invited by the conference's science committee to present here. And then I also need to acknowledge Surge, which has made funding available for the various publications that have emerged from our work, and then the various anonymous reviewers for our paper. And of course, this publication would not have been possible had it not been for the numerous articles submitted to review and that are currently in the peer review or in the preprint databases on the web. Thank you to all.
Thank you very much for that exhaustive summary of the literature that we have. I realize that we are running out of time, so we have time for just one question. We'll have to miss the break so that we can stay on track for the rest of the meeting. So Juli, please, could you go ahead?
Sure. It's a tough for one question. There are a lot of questions about using R0 and RT, and the other ones are about synthesizing the drivers and all the information you put forward. And we will post those questions in the HU comment. So the question is, it's from Mercedes Pasquale actually, understanding R0 is about understanding early emergence. which is relevant and most tractable to identify climate drivers. It's the same as understanding the initial growth rate for an epidemic with a little r, but to understand seasonality, we'll have to work with data beyond this point, namely RT in a sense. How should we lead with the problem of rapid changes in the level of testing that can affect R, R naught, and RT? So any sense of how we deal with rapid testing that's going to affect our ability to model on whether it's the mechanistic models or statistical models. Dr. Smit, are you there? Chris?
Yeah, I see him there, and he seems to be unmuted, but I think his program is frozen. So
Perhaps we should
come in
just go
in the
on,
next,
right?
yes. Well, I would say a big thank you to Dr. Smit and Prof. Thomson. And we will now be going into the panel discussion, and this will be moderated by Jen Stowell. So over to you, Jen.
Okay, so we'll now begin our panel discussion on forecasting and projection. My name is Jennifer Stoll. I'm a postdoctoral researcher at the Rollins School of Public Health at Emory University, and I'll be moderating our discussion with our expert panelists. So I'll just quickly introduce each of them. We're joined today by Dr. Jeffrey Shaman. He's a professor in the Department of Environmental Health Sciences, and he's also the director of the Climate and Health Program at the Columbia University Mailman School of Public Health. His research focuses on the survival, transmission, and ecology of infectious agents, including the effects of meteorological and hydrological conditions on these processes, and the broader effects of climate and weather on human health. Dr. Rachel Baker is a postdoctoral researcher at Princeton University, where she studies the implications of climate and climate change on the spread of infectious diseases. Her work primarily focuses on the implications of on directly transmitted infectious infections such as influenza, respiratory syncytial virus, and most recently SARS-CoV-2. Dr. William Pan is an associate professor of population studies and global environmental health at the Nicholas School of Environment and Duke Global Health Institute at Duke University. He's a biostatistician and environmental epidemiologist with over 20 years of experience studying the impact of human environmental dynamics on health. His work focuses on malaria early warning and the environmental health impacts of artisanal gold mining and mercury exposure. And finally, Dr. Francois Engelbrecht is a distinguished professor of climatology at the Global Change Institute of the University of the Witwatersrand in South Africa. He specializes in climate model development and the simulation of African climate variability and change. Dr. Engelbrecht currently leads the development of an African-based Earth system model. And recently he has led investigations on seasonality and COVID-19 in South Africa. So thank you to each of our panelists. So we'll start off with our discussions with brief opening remarks from each of the panelists and followed by discussion questions. So in the interest of time, we do ask that each of our panelists keep their opening statements to about 5 minutes. During the remarks, we'll just remind the attendees during the remarks and also the following questions. The attendees can continue to type questions in the chat box. Any questions that we aren't able to address in our live session will be entered into the AGU Connect discussion site for the symposium, where we can continue as a community to exchange ideas after the session. So we'll go ahead and proceed with opening remarks in the order that the experts were introduced. So we'll start off with Dr. Shaman.
Hi, everybody. Thank you for having me here. Pleasure to be on this panel. I thought I would talk very briefly about the rationale for why we need to consider some of the seasonality of COVID-19 and why people are particularly interested in whether or not this disease is driven by meteorological conditions in particular, and its transmission modulated. So to see this, you have to step back perhaps and look at some other better studied disease systems. We have influenza, which is in temperate regions of the world, a highly seasonal disease. It appears in the wintertime, and there's not much activity in the summertime. There are three hypotheses that have been put forward to try to explain why this seasonality in temperate parts of the world manifests. The first has to do with changes in person-to-person contact, the fact that people spend more time indoors, which facilitates the transmission of the virus and could lead to some of these spikes that you see that would lead to a phase locking, such that you get more flu in the wintertime. The second has to do with disruption or really a modulation of your immune system. Here, the idea is that during the wintertime, there's less sunlight, day length is shorter, the sun's at a lower angle on the horizon. Consequence of that is that there's less vitamin D and melatonin production that suppresses your immune function, which may make you more susceptible to infection, and furthermore may make you less capable of clearing an infection once you have it, such that you're more contagious. You put these two effects together, and that in and of itself may also lead to a phase locking, one that's really guided by external conditions, in this case sunlight, guiding our immune function. The last, however, has to do purely with meteorological conditions. The idea that perhaps there's modulation of the survival, the viability of the virus, once it's expelled from a human host out into the ambient environment through coughing, sneezing, breathing, speaking. Once it's out in that environment, the viruses tend to be fairly wimpy. And there's been a number of laboratory studies that have shown that, in fact, they are modulated, their survival, that viability is modulated by temperature and or humidity conditions. Seems to have settled more on the idea that absolute humidity conditions in the environment, the ambient air, for reasons that are really not clear, the physicochemical processes of why those ambient atmospheric conditions disrupt the viability of the virus in a droplet take place, it's not totally clear, but it's been fairly consistently shown in laboratory experiments just with the virus aerosolized on surfaces between animal models, the transmission of the virus, that at drier humidity conditions, which is what manifests in the wintertime in temperate regions, the virus is more viable, survives longer, and transmission is facilitated. We see this pronounced cycle in flu. You see it epidemiologically when you look at population studies of how we have peaks of flu in the wintertime. In addition, there are many other respiratory viral agents, some of which have a similar seasonal cycle, but not all do. But one set that does have a similar seasonal cycle to flu that's locked with it are the endemic coronaviruses. There are 4 of them that circulate in human populations, and these go by funny alphanumeric names like OC43 and HKU1. They cause very mild colds typically. They're not really typically medically attended, but they have really an identical seasonal cycle as influenza. However, unlike influenza, because they're so minor in their effects, they haven't been studied very much. So we really don't know if they are similarly modulated because of humidity conditions, if it has to do with temperature, if it has to do with radiation, UV radiation and sunlight exposure. These circumstances, these relationships have really not been investigated. However, we are left with this possibility that given that the endemic coronaviruses have the same seasonality as influenza, perhaps they are similarly modulated by humidity conditions in the environment. Furthermore, we have this novel coronavirus, SARS-CoV-2. It's a beta coronavirus that's most closely related to these human endemic coronaviruses. And the concern is perhaps it has a similar seasonality. And that has been the outstanding question that's been addressed. And the issue is really whether that seasonality is pronounced enough to result in any sort of abeyance of transmission during the summer months. I think it's fairly safe to say at this point that that is not the case, and that the gross lack of immunity in the population, or at least sufficient lack of immunity in the population, has allowed this virus, even though it may be actually modulated so it's less transmissible during summer, to still transmit at this time. We've seen this happen in the United States, in other portions of the Northern Hemisphere, in Northern Mexico, certainly. We've also seen transmission in the deep tropics in places like Amazonas, Brazil, where Manaus is, where there was a lot of transmission, even though it's quite humid and warm in that location. So what we're left with is this possibility that the virus actually does have some seasonality, but right now, given that it's a novel pandemic virus, there's not enough modulation caused by that seasonality due to weather conditions to actually really produce any marked changes in the transmission. That may change over time. It is quite possible, like a flu, like the 2009 pandemic flu, like the 1918 flu, like the 1968 pandemic flu, that this virus will settle into a pattern of endemicity, where people are subject to repeat infection from it over various timescales. And at that point, if it is indeed modulated outside the tropics by conditions such as humidity or maybe temperature, it will settle into some phase lock pattern where it becomes a wintertime disease. Still remains to be seen, but that is really, to me, one of the critical outstanding questions with relation to this virus and how it is affected by weather conditions. I'll stop there. Thank you.
I guess I'll go ahead with my comments. Let me know if you have problems hearing me. So thank you to the organizers for inviting me to talk on this topic. I'm going to talk about some of the work that we did on climate and COVID-19. I think it touches on both the comments that Professor Shaman just brought up and some of the other things that we've talked about in this conference so far. So I'll start by saying that most of my pre-COVID work is looking at how climate affects the transmission of directly transmitted diseases with a view to thinking about how climate change might alter patterns of infection in the future. And often when we do this work, we use large observational data sets, so at least multiple years of data. And we need these larger data sets to be able to disentangle the climate drivers from other factors that affect transmission. And obviously when it came to thinking about SARS-CoV-2, we didn't have those sorts of data sets available. So our approach was instead to look at how climate affects the transmission of some of those endemic coronaviruses that we just heard about. So these are common cold causing viruses that we haven't given that much attention to before. So we estimate an effect of climate on the transmission of those viruses, and then we ran our epidemic model to simulate a pandemic outbreak across different climates. So Northern Hemisphere, Southern Hemisphere, the tropics. And we found that large outbreaks were possible everywhere, sort of assuming the climate dependency of those viruses. Large outbreaks were still possible everywhere, large pandemics. And of course, this is because that lack of population immunity, that high susceptibility really is a fundamental driver at the pandemic stage. And the virus is just going to spread really well no matter the climate conditions. And so this has been something that's been sort of brought up by people at the conference and other people in the epi community, the idea that summer wouldn't make the virus go away. And it's something we've now seen borne out in the high cases in Florida, Texas, India, places with high humidities, high temperatures, high UV index. And so to reiterate, we're not saying that the virus is not sensitive to climate. We're saying it could be just as sensitive as seasonal influenza. However, at this stage, you just don't see that. You don't see that signature. It's just we're in the pandemic stage, not the endemic stage. And in our model, we actually run it forward, 10 years. And you can see after, say, 3, 4, 5 years, the virus eventually settles down. The cases settle down into more of a sort of seasonal outbreak. So that's the work that we did. And I'll finish with just kind of 2 points looking forward for discussion. Firstly, I think that understanding the climate drivers of SARS-CoV-2 is still important, especially as susceptibility declines. We may see increased sensitivity and increased sensitivity to climate and kind of more signature of climate in future cases going forward. And the second point, very relevant to our paper, but I think that we should, when we conduct this research on climate and SARS-CoV-2, we should not lose sight of the broader epidemiological context. And that was obviously the case with our study, kind of thinking about susceptibility and realizing that, climate may be important, but susceptibility is kind of swamping everything at this stage of the pandemic. So I think we should be paying attention to a couple of things now, serological surveys that can give us a sense of where we are on that kind of exposure spectrum, and some of the kind of newer studies on immunity to the virus and whether we have a waning immunity, how long immunity might last. I think it's important to kind of be paying attention to those. And when we do our work on climate and COVID, we kind of, we conduct it in context of thinking about some of those other things as well. So thank you.
Hi, everyone. I think I'm next. Thanks again. I want to thank the organizers for inviting me to participate in this panel. The nice thing about going third is that I think a lot of things have been said that I won't rehash, but I agree with completely. I wanted to actually start with a story. It's very similar to what Professor Smit was talking about. My very first project was a collaboration with an ecologist and an entomologist in Iquitos in Peru. And we were trying to understand the seasonal dynamics of malaria as they relate to seasonality of the vector of malaria, which was Anopheles darlingi. And the plan was to collect 18 months to 24 months of data. And the entomologist and ecologist both were adamant that there's no way that we could possibly create a model to capture the seasonal effects of malaria with just 2 years of data. We went back and forth in this, and I understand their point, because in some ways, from a statistical point of view, you have a sample size of 1 or 2 cycles per year, if you're lucky. And so if you're trying to capture and model those cycles, you can't really do that with 18 to 24 months of data. And so here we are with COVID, as Dr. Smit had said, we haven't even completed 1 cycle. We haven't completed 1 seasonal cycle yet, but there are a tremendous amount of articles in literature, both in preprint and reviewed, that state very strongly relationships between different hydrometeorological parameters and COVID risk. And the things that I've been worried about with a lot of those publications are not so much the scientific debate, because I think it's from a science point of view, I think it's fine. And we should be discussing the importance of those parameters with COVID. The problem with COVID is that we are under a microscope by the public as well as policy. So every person sees the results that we produce, and they are changing their behaviors based on headlines in newspapers. So I go back to think about what's happening in Florida, what's happening in tropical areas where we had first published that UV in summertime would be reduced transmission. And I go back to think how much death we have actually caused by producing articles that might not have been up to the standards that we would normally put in other kind of disease contexts. And so that's something that worries me tremendously, and it's something I think Dr. Smit was alluding to in his presentation. The other point I wanted to make, and I think it was just made with the previous speaker's comments, was the coupling of climate with other parameters on the ground. So I do a lot of work on human environment research, and we have some publications right now under review. One is on the US, looking at the variation in hydrometeorological parameters with COVID death and COVID propagation. And we look at this by state and region, and what we find are very, I won't say inconsistent, but essentially different relationships that are occurring across the country once you account for things like different policies being implemented on the ground and different characteristics of social systems on the ground. We also have another article under review that looks at biodiversity and COVID. That's on a global scale, and we see differences by high income versus low income countries, health systems, and the infrastructure that health systems have in different countries, and how biodiversity might be influencing COVID. It's very hard to make these relationships at a global scale, but I just want to make sure that we remember that the coupling of humans and the environment means that as we look at climate and land cover, for example, humans are responding to that. And COVID, in this stage of the pandemic, it's very important to remember that, as the other speakers have said, we're very early on. So we haven't quite reached a stable point to be modeling this seasonally. And the last point I wanted to make was the role of aerosols. This was mentioned, I think, briefly yesterday, and maybe was a point of debate. I had to drop off, so I couldn't hear the whole the panel. But the role of aerosols, July 9th, WHO finally came out and said that aerosols might play a role in transmission. And then there's a recent study with the Diamond Princess cruise that stated up to 60% of transmission might be due to aerosols. Now, I think we do lack studies to tease apart what the difference is between aerosol transmission and close contact. But I think it's an important question to ask how climate environment is influencing aerosol density. I know in a recent collaboration that I've had with a colleague at Duke, who's an atmospheric scientist, Prasad Kasabalta, he and I have helped create a COVID risk tool that is a web tool that allows faculty and students to put in ventilation rates, inhalation rates, and their own belief of risk in their community to calculate, what their actual probability of infection would be over the course of the semester. It can be used in schools as well, but that kind of link to aerosols is something that I think that needs to be studied a little bit more. And I hope we have more conversations about that. So I'll stop there.
Good day, everybody, from deep in the South African lockdown. I'll start by giving my perspective in terms of the COVID-19 seasonality problem and the prediction of infection rates as a function of seasonality. I started working in this field back in March this year, but from the perspective of numerical weather prediction. And as we've seen from our first keynote address today, if there is indeed pronounced seasonality in COVID-19 infection rates, then of course, numerical weather prediction of weather anomalies may well turn out to be important deeper into the future. Starting off working on this problem, I couldn't help to be reminded of something my professor in mathematical logic told me about 20 years ago. Namely that just because every fairy has two wings doesn't mean that fairies exist. And I think that is such an important piece of guidance for when we are addressing the COVID-19 seasonality problem. Effectively, if there is seasonality in COVID-19 infection rates, it will have profound consequences. And the first of these that I'd like to highlight today is the possibility of seasonality-induced second waves. These waves, should they develop in the upcoming winter of the Northern Hemisphere and deeper into 2021 in the Southern Hemisphere, will of course finally settle the COVID-19 seasonality question. So we do not have to wait that long before we will have an answer to our question we are posing at this conference. But of course, we ideally want to answer this question ahead of the occurrence of these second waves, so that we can adequately prepare for these. So I'll soon make two statements about how I think we can solve the seasonality uncertainty ahead of the occurrence of these waves, if they are going to occur, of course. But first, I just want to say that until we have not solved this problem, we have no choice but to prepare for the possibility of such scenarios. I want to, in this regard, point out what has happened early in this year. We know, of course, that there were great expectations that the Northern Hemisphere summer, with higher temperatures and higher values of humidity, would greatly reduce infection rates. And as we all know, that has not occurred to the extent where the disease was really contained or significantly slowed down in the Northern Hemisphere. So that hasn't happened. And in that case, the assumption of a pronounced COVID-19 seasonality effect was the wrong assumption to make. And we must be extremely careful not to make the same mistake right now as the Northern Hemisphere moves into the next winter. Right now, the right approach is to assume that there is pronounced seasonality in COVID-19 infection rates and to develop epidemiological models that respond to this forcing, so that we do have the tools to predict the outbreak of these waves, should seasonality indeed exist in the infection rates. How are we going to answer this problem, or to solve this question, to answer this question ahead of the occurrence of second waves? I think there are two possibilities. Most likely, the solution will not come from any single study, but from considering multiple lines of evidence. And that is an approach that is in fact very commonly used by the Intergovernmental Panel on Climate Change when evaluating future projections of climate change and trying to make confidence assessments of future changes in climate. So quite likely it will be by considering empirical data and case data from several different countries and cities in combination with inverse modeling approaches, looking at a multitude of different sources of information that will lead us to making some form of confidence assessment of whether there is seasonality in infection rates. There is, however, another possibility I would like to mention, and that is stemming from our own work in South Africa, using a dynamic epidemiological model that is sensitive to climate. And that is that I think we should not look at only how infection rates are changing over time, possibly in response to weather and climate anomalies. Almost every single study we've reviewed in the review paper my colleague AJ Smit discussed earlier today is looking at the time evolution of infection rates, or effectively the effective reproduction number over time. What I'd like to propose is something different, and that is now written up in a preprint I've been circulating to our group, written with my colleague Bob Scholes at the Global Change Institute. There may be value in looking at the more complete set of dynamics of the disease, and specifically how the number of infected change over time as a function of the number of susceptibles in the population. So the epidemiologists will be well familiar with the so-called SI, susceptible infected phase trajectories of an infectious disease. And seasonality is likely to reveal itself in very specific characteristics of these orbits on an SI diagram. So this gets a bit technical, but if we can find a region or a country where social distancing or lockdown has been maintained at more or less the same level over several months of time for seasonality to have an effect, we may be able to distinguish the clear signal of seasonality. That's where I will leave it for now. Thank you.
Okay, thank you very much to our panelists for your opening remarks and lots of food for thought. So in trying to kind of synthesize a lot of these different points that you make, I'd like to start off with kind of the question that gets at this lack of immunity that might be masking some of these drivers that we're hoping to see. So, you know, given that this might be happening and kind of getting at that second wave that we might expect to see. So will these second waves only be evident after perhaps a certain higher rate of immunity or a vaccine or something like that comes out?
So maybe since I did mention this topic, I can maybe offer a first answer. So second waves can of course develop, to a very large extent, it depends, and the severity of these waves depend on the proportion of the population that remains susceptible after the first wave have surged through the population. Now, right now in South Africa, and that is also the case in many South American countries, we have not been able to contain the disease. So as many people in this conference will know, we are currently having a tremendous surge in South Africa, already well over 500,000 recorded cases. We are probably one of rather few countries in the world that may end up 2020 with having reached herd immunity. Okay, that's quite a shocking thing to think about, but that is currently what the official South African predictions issued by our National Institute for Communicable Diseases are indicating herd immunity being reached somewhere during the course of this year. So there's much to learn from this. This is perhaps the only good thing that comes out of this. But if we look at what the current state in New Zealand, if I look at Southern Hemisphere countries first, if we look at the current Australian battle to recontain the disease, if we look what has the success in containing the outbreak in China, in South Korea, across the European Union, right now it seems to be successfully contained. There, a very large portion of the population remains susceptible moving into the next winter. And what modeling tells us is that if one should let your guard down and relax social distancing and relax non-pharmaceutical control measures, and in the absence of wide distribution of a vaccine, there is a tremendous vulnerability for second waves that can break out and that can in fact be worse in terms of the peak infection than the first wave. So, and we should see the gradual build-up of infections as winter approaches in these different regions in the world. Of course, in the absence of control measures, that is the condition.
I think just to sort of jump in, the second wave, I think there's kind of a distinction between a second wave caused by, us backing away from control measures and because we haven't reached herd immunity. And so you see cases pick up again, and, the media is kind of jumping on this idea of the second wave. And that's what's going on. I think it's not because we've reached herd immunity. But the sort of second type of second wave would be we've reached herd immunity, and that's when the kind of susceptible dynamics kind of hit in. We reach herd immunity, and then there's some return to susceptibility, and then you see a second outbreak at some point later. So I think maybe that kind of sort of answers how you brought up the question in terms of susceptibility. But I think there was kind of a distinction there between what a second wave might mean.
And I would agree with Rachel. You unfortunately have to define what you mean by a second wave. Is it just a period of abeyance and then a return? And is it due to a lapse in control? Is it due to some what's called immune escape, where the virus has shifted? Some people will refer to past pandemics like 1918 in the second wave. They'll try to define it as something that might have happened, even though they don't have direct evidence of this, genotypically, where you have some mutation in the virus that caused it to behave differently and evade immunity in a different way. But putting into context all further a little bit what Rachel said, we have a dynamic here where it's possible people can be infected more than once with this disease. And the question is, where do you get where you would get to what you think of as herd immunity initially? What number of people do you have to actually infect in a population to get to that? There's a theoretical estimate that's very simply and crudely calculated based on the reproductive number. There are a number of arguments floating around mathematically and mathematical epidemiology that it may actually be lower because of small world clusters and escape mechanisms that take place. That may mean that you actually only need a substantially lower number of people infected to bring up to a level of herd immunity. And then you also have the issue that there may be a portion of the population that actually has some level of pre-existing immunity to this virus. There are studies that are out there that have shown that people have CD4 plus T helper cells who have never been exposed to it. This is taken from blood samples that were taken prior to the pandemic, and a third of people in vitro demonstrate some level of cross protection. How that actually manifests once you get to a person, we don't know. So the level that you need to get to in order to reach herd immunity is unknown, and it's certainly modulated by the control measures that we have in place. But the long-term question, one could say the trillion-dollar question is, are we subject to repeat infections with this virus? And that is something we don't know. What we do know from endemic coronaviruses, for instance, is that 90% of people in this world have antibodies against each of the 4 endemic coronaviruses, and yet we get them repeatedly. We get them all the time. That antibody presence does not confer infection against those same coronaviruses. My own group had a field study where we've actually documented repeat infections in individuals, and we had a dozen individuals out of a cohort of 200 who experienced repeat infections of endemic coronaviruses within the span of a year. Some of them had 3 distinct infections with the same coronavirus, OC43, which is a beta coronavirus, which this new virus is. So the question is, are we going to be subject to repeat infections by this virus? And if so, at what time scale? At what time scale does our immunity wane from the prior infection, and what rates does immunological drift, immune escape take place? What antigenic drift take place that would facilitate the ability for us to be repeatedly infected? And then the last question, which is the painful one, is, are we going to be subject to the same severity of symptoms or the same likelihood of severe complications and risk of mortality upon repeat infection? Or is it going to be milder? Or is it even going to be more severe, as what happens with some diseases such as dengue with antibody-dependent enhancement? So we have an enormous set of unknowns here that are going to factor into whether or not people are getting repeat infections. And then you overlay on that whether there's a seasonality that's going to drive when those infections are taking place. Is it going to coincide with the influenza season, for instance?
Yeah, and that kind of brings me to the next question that I wanted to focus on, and this kind of goes back to something that Bill was talking about kind of bringing us to talking about coupling with geography and variability and differences in scale. So can we kind of start talking about some of those things that we need to be considering when we're making our models and things like that, and how careful we do need to be when when communicating some of those things? Because again, when we say, oh, UV is gonna whack things out and things like that, and sometimes these things can be tricky, especially in the pandemic stage of things. And I don't know if that's making a lot of sense, but yeah, maybe we can start talking about kind of the idea of scale and how one model isn't necessarily going to be true for the entire globe.
I can talk a little bit about that, and others can feel free to chime in. There's a pretty long literature on coupling of humans and the environment, even humans and land use change, humans and climate change, and there's been both conceptual and I would call sociological demographic models, as well as more ecological environmental science models. And there's lots of work on this. And so when you think about in the things that we do, both for malaria as well as for COVID, when we think about what is the risk that a person has based on an environmental driver, we always try to think about what are the feedbacks between human response and an environmental response, and how do those feedbacks work synergistically or antagonistically to put a person at risk. And so an example of that might be you have increasing temperatures, say in northern North America, Canada border with US and Mexico, US and Canada, versus increasing temperatures in the South. Well, if you have 5 or 10 degrees increase in the north, you might have people going outside because now you're talking about pleasant temperatures for those people. But you have a 10-degree increase in the south, say Florida and Texas, and it goes up to 100 degrees Fahrenheit, you might have people moving indoors to seek air conditioning. And those responses are very different. And then you talk about what's happening in a low and middle income country when you've got rising temperatures. A lot of those behaviors are different if you're talking about rural areas versus urban areas, indigenous versus non-indigenous communities. And so I think understanding human response is critical, especially for coronavirus, because as we have kind of mentioned already in this panel, there's so many unknowns that I think the kind of first step is to understand human response to different climate drivers or different environmental drivers, and then understanding how that response puts us at risk.
I'll jump in. So if we consider the basic COVID-19 seasonality hypothesis, if I can put it like that, if we make the basic assumption that infection rates are highest in cold and dry climates, and then infection rates decrease as we encounter higher temperatures and higher, say, absolute humidity, then there are certainly certain parts of the world where it will be easier to detect a climatological signal in COVID-19 infection rates. And this will for a start be the so-called mid-latitudinal regions of the world, more or less between 20 degrees and 60 degrees latitude in both hemispheres. If one looks at this humidity temperature cycle specifically, the regions in the world with the strongest signal are the subtropics, more or less 30 degrees to 35 degrees in both hemispheres. The seasonality signal under this basic assumption is to be markedly weaker in the tropics and also markedly weaker in the very high latitudes, simply because temperatures are generally low. There is seasonality, of course, strong seasonality in the high latitudes. But temperatures are generally so low that under this basic hypothesis, you will not see the seasonality so clearly. And this is probably part of the solution towards answering the COVID-19 seasonality question. Yesterday, we've heard about a study that is considering infection rates across 500 cities across the world in the early stages of the outbreak in different countries. And by carefully comparing, for example, the rate at which the effective reproduction number was changing in those early stages, as one encounters lower or higher temperatures in these respective countries, it's perhaps from that type of assessment that we will derive the answer to the question we are posing.
Okay, so we have, I guess, one last question that I had, and then we can perhaps take a couple of questions from the audience. So in thinking about all of these things, and considering a lot of the literature that has been put out there, whether prematurely or not, what are the most concerning issues in drawing some of these connections that as we saw with AJ's talk about avoiding kind of some of the spurious correlations that might be put out there right now? What are some of the most concerning issues right now, in thinking about how we avoid communicating the wrong idea right now, because we do have so many things that are kind of masking what might actually be happening underneath.
So I'll jump in first. So the point I made at the end of my opening statement was this idea that we should keep mindful of the epidemiological context, and that was a little bit thinking about some of the early studies that came out with using these kind of regression approaches that were kind of saying, climate's important, it's temperature, or climate's important and it's humidity, and we found this significant effect. And firstly, I'd say that I think it's probably very hard to identify those effects right now. As we've talked about this conference, there's so much going on, and maybe looking at these early growth rates is a good way of doing it. But I think the second point is, we need climate. We may find this a significant effect on log cases or log death rate, but we we need to kind of put that in a bigger context of whether that matters right now. And I think this kind of idea of, you know, susceptibility being a big driver at this stage, some of those studies kind of missed talking about that second piece. And so there's a real concern that that could be misinterpreted by policymakers reading those studies thinking, oh, the virus is going to disappear when it gets warmer, you know. So I think that's why I kind of stress that point about we should be thinking about these factors together.
I would also add that it's very important. I think we can all recognize that there's a bit of the Wild West out there. Everybody wants to rush in and be helpful. A lot of the journals have policies now that allow you to preprint and to talk to the media. They don't embargo. And this is a very important topic. But people are also, in some ways, competing to get their results out really quickly, which leads to some rush that Dr. Pan alluded to as well, which we have to be very, very careful and resist the urge and not think about publication so much. I think it's also very important to consider the data. The data have not allowed the type of analysis, even if the statistical analysis Dr. Baker alluded to were to be fruitful, which I don't think it would be. I do agree with her points that you need to look at this in the context of a dynamic system. But even if it were, the data very often aren't sufficient to allow you to handle cross or international issues associated with differences in data collection, rates of seeking care, reporting rates, and willingness to actually be open about what kinds of situations are actually manifesting in different countries, which makes it very complex. But you also touched on another issue, which is what about the fact that the media takes this and runs with it all the time, and it's happening continually. And what's happening very often is that there are very political issues at play, and I don't just refer to the US, it's happening all over the world, where certain politicians are really looking for confirmational affirmation of their pre-existing ideological views on how we should be treating this. And they will grab at information that gives them the answer that they want. And you know, the classic case was the Santa Clara study that was done on antibody prevalence that really did have some sampling and statistical issues associated with, specifically with the specificity, the false positive rates of the antibody tests that we're running. It's problematic because that may be the most scored paper in history on altimetric. I've never checked it, but I believe it was. That's what I heard. And it's a preprint. It hadn't been peer reviewed, and it's had trouble with peer review because of many things that have been pointed out by a range of epidemiologists, biostatisticians, and statisticians. Lengthy blogs written about it very immediately about problems associated with the study. We had similar issues with one that was put out, not to point fingers again, in PNAS that had to do with aerosol transmission, where the paper itself was just not strong. It's very, very important to recognize that these types of hypes of these papers are going to come about because they're telling some people what they want to hear. And so we would all be very well advised to be very careful about what we put out there and not try to put something that could be sensationalized unless we really feel that it's a comprehensive and airtight piece of research.
I just add on one point to that. I completely agree with what Jeffrey is saying. There's something called science diplomacy that I feel is something that more and more scientists should be involved in, which in some ways can be described as controlling your own story. So with an increase in preprints, I strongly feel that the scientists putting out a preprint prior to review, they should make sure they create their own press releases. They should make sure that they try to control the story so that the press doesn't misconstrue things. I also think working closely with stakeholders, not just the press, but policymakers, in translating what your science is and making sure they understand what the science is critical. That's one way to make sure that, you know, if you have an article that has limitations, but you think it has an important contribution to the science of COVID and seasonality or climate and COVID, you know, make sure that you are communicating those limitations as well as the interpretation of the results.
All right, thank you so much. I'm going to go ahead and turn the time over to my colleague, Mark Shimamoto, who's been watching the chat, and he's been closely monitoring the questions that have been posted there, and he's picked one or two to pose to the panel.
Yeah, thank you, Jennifer. I think there's been an active discussion once again about issues around science and risk communication, uncertainty of data and scientific integrity. But one area that was being discussed a little earlier was this idea of compound modeling and forecasting, and the confluence of hazards become an important factor when modeling or forecasting the evolution of COVID-19. So I was just wondering, I wanted to open up to the panelists on how these current models are maybe addressing this issue, or are there other models that you've come across when it's doing coupled modeling with climate and air quality or weather events, et cetera, that might be ripe or relevant for a COVID-19 integration?
Well, I can say that we are engaged in a study that we're finishing up to look at hurricane evacuations in association with COVID-19 to try to understand what are the best policies for how you might distribute people or try to direct people in the event of a landfall hurricane. Obviously, we had one take place, so it's kind of timely. It's been a very active hurricane season thus far. But I think studies like this are really critical. I can say for my own group, because we were very early on making projections at county scale for COVID in the United States. We were approached by the USGS, Army Corps of Engineers. You know, we put all our projections out there. We try to give a lot of caveats. It's freely available for people to use, but we were approached to them because they were concerned about spring flooding in the Mississippi Valley and how they were going to be able to affect disaster relief in the context of COVID-19. And I think those questions keep coming back over and over again. Phoenix, Arizona has had wildfires around it that have been really compromised air quality and been really problematic while they're having a very heavy COVID outbreak right now. So these issues are exacerbates. I mean, these are the kinds of complicated downstream effects and stressors that we really want to be mindful of when we're thinking about climate phenomenon and how they actually bring into relief other problems, inequities, environmental health inequities, social injustices, problems associated with displaced communities, disadvantaged communities, et cetera. COVID brings that into relief, but having another effect on that, like an extreme weather event, is only going to exacerbate it further. Yeah.
Did anyone else want to weigh in on that? Francois, I think you're on mute.
Thank you. In the Southern African context, the main risk in this regard is probably the occurrence of drought. So many people will probably know about the so-called Cape Town Day Zero drought when the city of Cape Town came close to running out of water, 2018. So just imagine a scenario where a city needs to deal with the COVID-19 outbreak, and at the same time, there are very strict water restrictions or even no water, like happens from time to time in some of the smaller municipalities in our own country. So fortunately, right now, we are not in such a drastic situation of drought in the country as we were back in 2018, because then I think it would have been even more difficult to cope.
Mark, I just comment one comment. In some ways, the way I interpret your question is, what are some of the best models we've seen? And I think Professor Smit commented a little bit on that. I would just comment that you can take the simplest multivariate regression model and compare it to the most complex compartmental model, and the simple model might be the best one because of the way it parameterizes variables that are adjusting for things that are important to the system of COVID, whereas the compartmental model might make assumptions that are incorrect. So I don't think that particular models are correct. I think you have to think about what is the correct statistical model, but also what is the correct application of the conceptual model with those statistics.
I think that's a good point too, and then communicating clearly those uncertainties and really targeting those results for making an informed decision. We are coming up to time. So again, we are collecting all these questions and we'll use these as functions to stimulate conversations in AGU Connect. But with that, I will hand it over to Jennifer.
Okay, well, thank you very much. We just want to thank our panelists once again for taking time to prepare remarks and to be part of this. We really appreciate all that they've shared with us. This has been a really fruitful discussion and look forward to ongoing discussion. There's a lot to be learned from this and so much more to be learned about this disease. We're now going to take a short break before heading to breakout sessions. So please return in 5 minutes and we'll have a brief introduction to the process.